Good evening, everyone. It's wonderful to see such a brilliant turnout of people, and I think it's because there's only two things that connect us all in this room. First of all, we were all born, and secondly, we're all going to die. So that's the connectivity. My name is Alison Kitson, and I'm the Vice President and Executive Dean of the College of Nursing and Health Sciences at Flinders University, and I shall be your host for this evening. And I suppose now that you know that I have a vested interest in the bit between birth and death, we are the caring profession, we are the nurses, the midwives, the allied health, all those people that sort of try and make it a bit better between birth and death. Anyway, I want to start by acknowledging that we're meeting on the traditional country of the Kaurna people of the Adelaide Plains and pay respect to elders past, present and future. I recognise and respect their cultural heritage, beliefs and relationship with the land, and I acknowledge that they are of continuing importance to the Kaurna people living today. Then I have to go on to emergency exit advice, and the good news is that we don't have the video that we normally play for you. And if you have seen that video, you'll know what I mean. If you haven't, then come to another Brave lecture and you will then be able to email me and say, Alison, you were absolutely right. But actually, the emergency exits are out that away, green, usual, and basically the meeting point is in Victoria Square. We don't expect anything untoward to happen, apart from a huge amount of enthusiasm and really, I was going to say killer questions, but then that wouldn't be appropriate. Okay, so welcome and thank you for joining Flinders for this research series entitled Brave. Now, has anybody been to any other Brave lectures? Oh yes, okay. So there's at least one person in the audience who may have heard the little spiel about why we call them Brave lectures. I'm not going to embarrass you, sir, by asking you to see if you can remember it, but you probably look as if you do remember it. But this is all about our founding Vice-Chancellor, Peter Carmel, who explained his ambitions for Flinders in the now famous quote, which he said, "We want to experiment and experiment bravely." So that was a call to ambition, boldness, courage, trying to think outside the box. And those are the characteristics that Flinders University is known for, both nationally and internationally. So Brave is not just a reflection of the extraordinary research that Flinders University pursues today. It's a call to action that harks back to the earliest days of our institution. And I think we as the research community of Flinders, can be commended for tackling some of these, what we now call wicked problems. They're the things that we all talk about, things that our politicians talk about, but somehow we don't seem to sort of move terribly far forward. So this notion of bravery and bravely is a concept that has captured the imagination of successive generations of Flinders researchers and continues to inspire us today. This bravery is evident in our researchers and our new research discoveries that we are sharing with the world for the greater good. And tonight we'll discuss what clinicians can do to improve the quality of end-of-life care to benefit patients and their families. And indeed, it's not just clinicians, it's carers, it's families, it's everyone in the community. 1 Australian dies every 3 minutes and 17 seconds. So the mathematicians in the audience will work out how many people have died in the next hour that we have been talking. And it's expected that death rates are expected to double in the next 25 years. Now, I was thinking, how come, like, if we're all going to die, how come the death rate's going to increase in the next 25 years? But of course, that's because of the baby boomers. That's people like us in this room, because never ever in the history of humankind has there been such a huge number of people who've made it to their 70s and 80s. So we are actually at the very point in history where societies across the world have never experienced this before. Now that is both a wonderful thought, but a very scary thought. And again, this shows you why the sort of conversations we're going to have tonight is so, so important. And the person who's going to kick us off tonight to have these hard conversations is Associate Professor Kim Devery, or Kim, because we like to be a bit informal here, don't we? Yes, because that helps people relax and have a conversation, even though I know we didn't give you any wine. So next time I'm going to be encouraging a bit more wine being flowing. Okay, so Kim is, she'll take us through the essentials vital to improve the quality and safety of end-of-life care in Australian hospitals. And Kim is an Associate Professor and Head of Teaching and Course Coordinator for Palliative Care, postgraduate courses in the College of Nursing and Health Sciences at Flinders Uni. And she's got an incredibly extensive experience as a nurse, not only in Australia, but in Africa, the US, and in the UK. And in her teaching, Kim really embraces a truly multidisciplinary approach, teaching and guiding doctors, nurses, allied health professionals, and community members in studies that will ultimately strengthen their capacity in delivering healthcare services to patients who are at the end of their life, which let's hope Kim will reach us whenever it comes to our time. So Kim leads a major national education and knowledge translation project called End of Life Essentials. That's free and evidence-based, and I don't think you can get anything better than that, which aims to increase professional skill and confidence in end-of-life care in Australian acute hospitals, where, by the way, most people die. So, and that's something that we really do need to think about. So, without further ado, please welcome Kim.
Thank you, Alison. You've stolen a lot of my statistics there, but I'll try to make them sound really exciting. So please cheer when you hear me say certain things you've already heard tonight, please. Let's begin at the end. And, you know, we will all die, every one of us, and we have done since the beginning of our humanity. But it's something we don't like to think about. And some people have talked about it as, well, the inventor of psychoanalysis has spoken about like looking into the sun. We don't do it. But the sun's ever present during the day, but we don't look into the sun. And he said death is always around us, but we don't think about it. It's a mysterious time with individual preferences. If I ask you just for a moment to think about what you would wish for at the end of your life. You know, some people might like to die in their sleep. Somebody would like to maybe drop dead on the tennis court. I want to die at home in my own bed. I just don't want to think about it. Some people just don't want to think about it. So how do we get to have choice at the end of life? And how do Australians die? So this is the road we're on at the moment. These are the 5 leading causes of death in Australia: coronary artery disease, that's heart disease, dementia and Alzheimer's, cerebrovascular disease, lung cancer, and chronic obstructive pulmonary disease, which is a lung disease. These are the 5 causes of death, leading causes of death in Australia, and they have been for some time. And when we look at the deaths when they happen, like when do we die, you can see there that about 66% of deaths happen when we're 75 years or over for Australians. Yeah, it's on. Can you hear me down the back? Yeah? Good. What a marvellous life we're having. We're dying, most of us are dying in very old age. So around 2/3 of Australians die 75 to 95 years of age. It's estimated that 70% of deaths are expected. Predictable, not surprising, after a long life and a chronic illness. And usually people don't have one of those things. They've got a smattering of a few of those things. So they go hand in hand. So this will be a surprise to you, that the numbers of Australians who die in the next 25 years will double. Thank you. And look, this is quite relevant for me because this is my cohort. Hopefully, if I live a long and healthful life, this is me. And this is what I say to medical students when I'm teaching them. It's in my vested interest that you know what to do when I'm a little lady coming in to the ED. I want you to ask me what matters. So we don't have much time. A life prolonged and an institutionalised death. This is where we are at the minute. So we might wish to die at home, but more often than not, we're dying in an institution. So we're dying in hospitals, residential aged care mainly, and home maybe. So, we've always had 100% mortality, but if you think back to the 1900s or the late 1800s, the life expectancy at birth was 55 years for men, and now it's over 80. In 1900, 25% of the population was dead before they were 5 years old. Today, it's less than 1% are dead before they're 5. In 1900, less than 5% died after 85. And now, 40% are dead after 85. It's a massive change in terms of humanity, a very, very short amount of time. 1900, that's King William Street, looking south, with horse-drawn carriages. And of course, we've got this very modernist building, which is the Royal Adelaide Hospital. And when it was being built and I knew all the statistics, I thought, oh God, I'll probably die in there, I kept it to myself. I didn't tell my family. But what a change, what a shift. And of course, in 1900s, the diseases, you would be fit and well 1 week and dead the next, because the types of illnesses that were fatal were infectious diseases, pneumonia, tuberculosis, gastrointestinal diseases, heart disease, really quick. And now it's exactly the opposite, slow, chronic dying almost. So slow, it's actually quite hard to see sometimes, and it is hard for clinicians to pinpoint when somebody is at the end of their life. Not days before death, but maybe a year or two. Very difficult to see sometimes. But, what do we do with all those years? When you think of it, that's my grandfather's parents, 1900s. What do we do with all of that extra time? I mean, it's 30 years more time. We all like to think that we talk about death. Oh yeah, let's talk about death. But only, 25% of people have actually done that. So we think it's a great idea, but we don't follow through on it. And even less have talked to their doctor about end of life. I find that really interesting. Great idea. We've got this long, long life. Let's not think about it. Yes, it's a good thing to talk about, but let's not do it. So we've had this outstanding success of our healthcare system that's really resulted in prolonging our lives. We don't save lives, we prolong lives. Many Australians live with these chronic complex illnesses well into their 80s and 90s, and they may have exacerbation to their illness, pneumonia, a heart attack, and our healthcare systems are very, very clever at getting us back on track. But what happens is we're never really the same as before that acute episode. Really, we have this long life. However, when it comes to dying, there's a disconnected, confusing, distressing array of services, interventions and relationships with healthcare professionals. Now, the Grattan report, if you're interested in reading about this, in 2014 released a report called Dying Well, and it's a very interesting read. And so our healthcare systems aren't really well designed for Australians who are dying. It's inequitable across Australia, and it's patchy. So hospitals, of course, where 54% of Australians die, it's really a place we go to. Hospitals are a place we go to when we fall, when we're unwell, when there's no other healthcare service available in the middle of the night. Logically, they are a place we go to. But also they're the place where a dying Australian on average may be admitted 4 times in the last 12 months. So we need to bolster up our community services. We need to bolster up care for people when they're at home. Are hospitals the best place for a life to end? It depends, but probably not from my view. Our clinicians in hospitals are enthusiastically active at investigating and treating illness. They're very, very good at that. And some commentators have talked about this conveyor belt to ICU. So you come into ED, and if you're not met by a understanding emergency doctor who can firstly recognise that you're at the end of life and ask you then, what do you wish or what matters to you, there is a conveyor belt to ICU of investigations and a cascade of treatments. We're not so good at identifying the end of life, but that's what our project is doing. We're educating people about that. And we're not so good at discussing end-of-life issues. So healthcare professionals, they don't want to hurt people's feelings, and many healthcare professionals went into their professions because they wanted to heal people and make people better. And so it's for some people feel quite challenged about talking about end-of-life issues. So what do people want at the end of their life? Choice. Now this was position paper from the UK that's been included in some of the Australian Institute of Health and Welfare's publication. I want to be cared for and die in a place of my choice. I want involvement and control over decisions about my care. I want access to high quality care given by well-trained staff. I want access to the right service when I need them. I want support for my physical, emotional, social and spiritual needs. I want the right people to know my wishes at the right time. And I want people who are important to me to be supported and involved in my care. It's really interesting. I always think about the beginning of life when I think about the end of life, and how much planning and discussion there is around pregnancy in the early years of a child's life. And there's a lot of choice, there's a lot of discussion, there's a lot of planning. And I think we really need to start thinking about that at the end of life. Now, this is some research from Australia. It's a systematic review, so they looked at a lot of research that had already been published, and they wanted to know what was, important. What do patients say they wish for? Well, honest communication with their healthcare teams. So when I ask somebody what will happen to me, they don't just say, oh yes, you're going home tomorrow, everything will be fine. They actually will say to me, would you like to speak about the future? Would you like to know what we think will happen? Or the future is uncertain. The ability to prepare for life's end. So the ability to talk with my family about what matters to me and how much I love them. To feel listened to, for somebody to be concerned about me, not my heart disease, not my lung disease. And being aware of my physical condition. So all of that information that the doctor and my nurse and allied health professional, all the information they've got in their head about me, I want to know what that is. So that's what patients say that they wish for. So you understand your illness and your future, and then you can start thinking about what matters when you're armed with that information. So then people often will ask, well, what will happen to me? Is this the end? How do I tell my son? He's living over in California and I haven't seen him for a few years. He knows none of this, that I've been in and out of hospital, because I haven't told him. So how do I tell him? And what health and community care services are available to me? These are common questions. At Flinders University, we were very fortunate to be competitively successful in a Commonwealth-funded program, and it began in 2015. And as Alison said, we've created education and practice change resources for doctors, nurses and allied health professionals who work in hospitals around Australia. They're evidence-based and peer-reviewed. That means we haven't done it alone. We've reached out to industry right around from coast to coast in Australia with peer reviewers and advisory groups. And I'm really happy to say very recently that we clocked up 10,000 healthcare professionals who have registered for our learning and our practice change resources, and that's just since 2016. So we're really proud about that. So we've really pitched it at the right level, and I think offering healthcare professionals something that they're not finding somewhere else. Of course, it's free and it's online, so people can get on when they like. To really understand what is compassionate, equitable, appropriate end-of-life care in the fast-paced hospital. And so this is what we want to do. We want to empower patients to direct their own care. So we want to be able to help clinicians do that. We want to recognise that patients could be approaching end of life. So we want to be able to help clinicians understand how to look for those cues. And one of those cues might be the patient asking, what will happen to me? We're educating clinicians to see end-of-life care as urgent care. This isn't something that at 9 o'clock at night gets to the bottom of the list of things that need to be done if a patient's in pain or they're wanting to talk with somebody. This is something that needs to be urgently attended to. And to be able to have courageous conversations about dying. So if a patient or a carer asks you a question about dying, about the future, that you can sit down with them and say, please tell me more. Tell me more about what it is that's on your mind. Not to say, oh, I can hear a bell and I need to go. These are beautiful questions as well. So to have compassion in your practice. And what does that mean? It's asking the patient, tell me what's happening to you now. What are your fears, worries and goals? Tell me. What outcomes are acceptable and unacceptable to you? These are really important questions, I think, no matter where you are in your life, but especially at the end of life. So what we did is we asked thousands of healthcare professionals around Australia, after they'd done their learning with us, what if they could change one thing in their practice tomorrow, what would it be? What was the one thing that they think that they could change in their practice to actually improve end-of-life care after doing the education? Curb my own avoidance. So, clinicians were, saying, I know I avoid this and I know I should stop doing it. I know I don't answer completely honestly when I get impromptu questions for patients and carers. So curb my own avoidance. Communicate more, better, listen. And some of those people said, I just need to be able to say the word dying because I can't say it now. So a patient might ask me, am I dying? And they don't feel as though they can say, tell me more. Listening is a very big skill at the end of life, to really tune into what the patient is saying, what worries them. Compassion, recognising another person's suffering and acting to relieve it. And we've got some great examples of compassion in the ED. We had the fantastic ED nurse who was on our advisory group, who's very interested in end-of-life care in that incredibly fast-paced and pressured environment, and gave us some wonderful examples of compassion at the end of life in that incredibly frantic, for me, paced setting. Understanding and sensitive to another. I should be more empathic in my practice. I should put my to-do list away just for a minute and just focus on this individual in front of me. Dignity. I really think the thing I can change in my practice tomorrow is valuing and respecting another person's viewpoint, the patient, even if what they value is very different to my own. Honesty. I can answer the questions of the patient and their family with honesty. Respecting patient wishes. It can be very, very tricky sometimes when a patient and their family may have very opposing viewpoints. But that's something that these clinicians said that they could change. And advocacy, stopping that conveyor belt so patients can hop off. And there's a whole team of professionals around you as a clinician saying to them, hang on a minute, this patient wants to talk to us about the care we're giving and we should listen to them. So that I found really interesting, and it gave me a lot to be optimistic for about the future and actually improving care. So what are the top tips for us mortals who maybe some of you may be healthcare professionals, some of you aren't. So how can we, approach this mortality thing well, in an informed way? Think about what matters to you, because ultimately planning for end of life is all about living. Think about what matters to you, what makes your life worthwhile now. You may be absolutely fit and well. You might not be, but what matters to you at this moment in time? Start talking to your family and friends about what matters to you. We have these discussions around our dining room table at home, and my husband's Indian, and my son was saying, well, do you want to be buried, Dad, or do you want to be cremated? And my husband said, I'll be cremated. And then we had a holiday in India, and then we were talking about, you know, the end of life and burial and cremation again, which doesn't happen all that often, but it did happen this time. And my husband said, I've changed my mind. I've changed my mind. He said, I think I'd like to be a little bit sprinkled in India and then a little bit sprinkled in South Australia. So now we've got all these friends putting their hands up. Well, I'll take you a bit over to India for you and I'll do the sprinkling. And it's not morbid at all for our 17-year-old son, but I would hate to be in the position where he didn't know what we wanted. Tell people more about what matters to you. And tell and ask healthcare professionals, can my illness be cured? What will happen to me? What are my choices in care? Or tell them, I never want to go to ICU or ED again. So what else can we do? Or I don't want to have that treatment, or I do want to have that treatment, but start those real discussions. And of course, there's the formal things that we should be talking about as well. It's not just getting in your mind and talking at the dinner table, but advanced care planning are really important. And there is an Advanced Care Planning Australia website that's got lots of information there for people who want to complete an advanced care plan, or even just talk about some of these issues as well. And a will, very few Australians have a will. We do have a will, and I've shown my son where it is. And that's a good thing to attend to if you want to do the life administration, advanced care planning and a will. And also, importantly, have a think about who would you wish to make a decision on your behalf in the event that you can't make those decisions. And have you spoken to that person? Now, that's a direct quote from a fellow called Peter Saul, who's an ICU doctor up in Newcastle. And he said his job in ICU would be a lot easier if people had had that type of a conversation, because then they would know who to go to in a crisis where the patient wasn't able to speak for themselves. But let's not forget that dying is personal, isn't it? It affects us all, family, friends, colleagues, neighbours. Bereavement, grief and loss are personal too, but potentially societal issues. A generation of grief and sadness. We need to work to create change across our public institutions to provide equitable, appropriate end-of-life care, especially in the next 25 years, before I get there. And we need to really look after carers, family caregivers, because they're needed to enable care in the home. And family structures and work patterns have changed dramatically since 1900, for example. Women have entered in the workforce. Families are really mobile across Australia and the world, and we greatly need to support Australia's carers and families. So, Flinders University has recently launched a Centre for Palliative Care, Death and Dying. And we hope to really inform policy and practice and governments across Australia in pushing forth some of the agendas when it comes to end-of-life care. As Alison said, Flinders has got a long association with excellence in palliative care. We've got nationally respected postgraduate courses, and this research centre is going to really, we've got a great track record at retrieval, synthesis, dissemination of palliative care evidence online, clinical research to improve care outcomes, primary partnerships and collaborations across many settings, acute care, primary care, that's community, GPs, and aged care as well. And also using technology to create solutions. So we're very proud that the university is invested in bringing us all together to push some of the research agenda nationally. I just wanted to finish with, I've got a couple of things to finish with. Hugh Mackay is an Australian he's a social commentator and researcher. He's a very interesting person, and I really like this. Some think of death as being the end of life, the final word, the final chapter of our lives, the closing door that's locked and bolted forever. Others prefer to think of it as the beginning, the opening of a new door into the great unknown. Regardless of what we believe, we're all going to get to that door. And I think with a lot of planning and a lot of talking and a lot of happiness and a lot of living, we can actually make our dying okay for us, okay for our families and our friends. Now let me see if I can get this to work. I've got just a little film. As you might know, it's Palliative Care Australia Week this week. And this is a film that's been produced by Palliative Care Victoria, and it's called Moments That Matter. So you can Google that, Moments That Matter, Palliative, and there's a series of films, and this woman's going to talk to us about love.
I met Matt on this website that was for older people who were wanting to find a partner. I saw the photo of him and I thought, he's got a beautiful smile. That was the first thing. He'd say things like, Nick Cave's going to Ballarat, or there's a Nick Cave movie on in Chapel Street. And I thought, wow, how come it took me so long to meet you? And from there on, the rest is history, really. His came first, and then a few months later, I was diagnosed with cancer, and we're both terminal. Did I feel like I'd lost everything? That's probably exactly how it felt. I didn't have any family in Ballarat to look after me, so what was I going to do? It was frightening. My first ever hearing of the word palliative was when my dad was dying and he was in a hospice. And so I thought, oh, palliative care, death. And I didn't really want to go there, but then I thought, we need help. And now I realise that palliative doesn't actually mean death. I've been told I've got between 2 and 5 years to live. That's still not death yet, but the palliative team are out there for me whenever I need them. I've cared for a lot of people in my life, but this time I'm the one that has to reach out to people and ask, and I'm not very good at it, but I just keep getting told that it's okay. I'm sure they're stumped for words sometimes, but they don't show it. They really do make us feel loved.
Okay, thank you.
Thank you, Kim. So we now have a panel discussion, and we've got Meg, Deidre and David, and who are going to come up. And Kim, if you want to... Now, the first challenge is they have to climb onto these stools. And then when they... And Deidre will be particularly challenged because she has some sort of contraption that reflects that she's got something wrong with one of her legs or knees or foot or something. But you can tell everybody what it is, because I'm going to get you guys up here, sit down, and then you're going to introduce yourselves, because I think it's much more interesting to hear you talk about yourselves than me read out what's been written in front of me. So let's start with David, and tell us who you are, what you do, and why you rocked up here tonight.
Hi, my name's David Holden. I'm a palliative care consultant. I work in the north of Adelaide and have an office at Modbury Hospital. I'm going to let someone else introduce me tonight. When I first got here tonight, I heard, you know what the problem with all you palliative care consultants is? You don't get enough sun. You all look like you need a good steak, a good glass of red, and you're too bloody earnest.
I didn't say it quite like that.
And I wasn't mentioning names, and I would acknowledge some of the truth in that. So I'll let that be a warning.
Okay.
I'm here because I love palliative care. I think adding life to the time that left is a wonderful privilege. And it's a message that I'm really delighted to be able to share and to speak to.
Thank you, David. Deirdre, hop along, Deirdre.
So my name's Deirdre Morgan. I'm an occupational therapist, and I worked in palliative care for about 13 or 14 years, and then I got suckered into doing a PhD, and now I'm researching in palliative care and teaching in palliative care. So I think why I'm here is I'm also really passionate about helping people have a voice that don't have a voice. And as you get older, or even not when you're older, because palliative care is not just for people who are older, that you're very vulnerable. And how do we support people to find that voice and to do the things that are still important to them while they both keep living but also come to terms with dying? So for me, it's both the living and the dying, and helping people cope with that, face that, hold that, and also then to help clinicians who are working in that space, because as Kim said, we're not all trained to be able to work and to support people. So it's about enabling clinicians as well to work in that space.
Thank you. And Meg.
Yep.
My name's Meg Brassel, and I'm called a consumer representative, but actually I'm not dying. And I guess I'm a consumer representative. I kind of think of myself a community representative because now 13 years ago my son had what was actually a good dying, and as a result of that, neighbours, family, friends would involve me in their dying or the dying of their parent. And I guess I learnt that it's more complicated and varied than what we personally experienced, but I really appreciate the benefits that a good dying has, not only for the person who's dying, but for all who are important to them in their lives. Yeah.
So we have a few sort of warm-up questions for you guys, which means that once we've asked the questions, then it'll be over to the audience. So keep thinking about the sorts of questions, the thoughts, the reflections. But Meg, you know, as someone who has had that role, having had the experience and being seen as a magnet to other people in the community, what has your experience taught you about what the community wants in terms of support and care at the end of life?
I think in part it depends on what people's experience of death and dying is. I wrote myself a couple of notes because I'm not good at thinking on my feet. But I think there's two main things, and the first one is that the person who's dying, that their suffering is reduced to an absolute minimum. I guess what professional people would call good symptom management. So the vomiting, the diarrhoea, the delirium are all dealt with efficiently and effectively and minimised. And the other thing I think that carers really are looking for is some guidance, information, some understanding about what's happening, because I guess when you're faced with something that you're not well experienced with and you're seeing somebody you care about occasionally suffer a bit, you feel like things are out of control. So it's a desire to be informed and consoled and directed and supported in a way that's useful, and so that you feel like things aren't out of control, that there's a point and a purpose to how
So
things get
it's
done.
that feeling of not being in control, having unrelenting pain, losing your identity of self. Deirdre, are those the sorts of issues from your research that come through from when you've been looking at this with a research lens?
I think there are a couple of things, I guess, that come through strongly. I'll go back a little bit first. So when I first started working in palliative care, people would come in for much shorter times. So people would often come in for what we call end-stage care. That's not so much the case now. I would see some people over a period of 12 months. So palliative can have quite a broad time frame. One of the things that I asked people in my research was what's important for you while you experience functional decline. Because while we can help to manage symptoms, we can't stop the fact that people will fatigue or get weaker. So what's important to you at this point in your life? And it's I think the key take-home message, which is, I remember saying to my supervisors, this is not rocket science, but I think sometimes the simple things we miss. And the key thing was really to ask people what's important. One man I spoke to said he would rather die than have to go to hospital and have somebody to wipe his bottom, because that was just so humiliating. He simply could not get his head around that. And he had head and neck cancer, and he was continually had saliva coming from his mouth because he couldn't swallow. But to have someone help wipe his bottom was far worse. Another man that I saw that same afternoon said to me that he was very frustrated because he thought he was going to be like the cockroaches and live till he was at least 100, because that's what his father had done. And he said, I don't care if anybody helps me with any personal care. I want to do the form guide because I've done that every Friday for the last 25 years, and that's what I want to do. Another mum wanted to have a shower independently, but also to be able to take her daughter to school. So everybody is different, and I think for me that when I teach students as well, that take-home message is ask people what's important, because it is different for every person. I think the other thing that's very strong, and there's an emerging body of research coming out around this from Denmark and Sweden, that being able to participate in things that are important to you, even if it's in a less physical way, actually helps you to come to terms with the fact that your body is changing and that you're starting to die. So cotton-wooling people and not letting them do things actually takes away that opportunity to help to adjust.
And David, do you think we've lost compassion in our health systems, or how do you as a medical specialist actually live that value that Kim identified as important?
That's a really great question. I have the privilege of working in a team, and I'm going to speak to specialist palliative care at the moment. The word presence is the word that keeps being told to me, and I delight in seeing that. And the best way I can describe it is that there's members in my team who, when they are with a patient at that moment in time, the patient is the most important person in the world to them for that period. And that just comes across. And I would call that as presence. The joy I find in palliative care is because I think we're in the business of restoring relationship, and I think we're in the business of offering hope. And people often look at me a bit strangely when I say that, because palliative care is all about end of life. I think when we get towards the end of life, our relationships break down. For some people, it's a breakdown with families or with function or with their roles, with their work, with their sports, with their understanding of God. But illness often separates us from the things that we love, the things that bring us hope and joy. And as best we can, I think in palliative care we try and restore that as best we can. And for some people it is about providing equipment to provide function. For others it's looking after emotional support or helping with families. But it's an opportunity to provide function. For other people it's spirituality. And I know we always think that, you know, the Port supporters and the Crow supporters have got the strongest religions in Australia. But have you guys ever met pennant bowlers? We hit every box. It's the physical bending down. It's the social having the drink at the bar. It is a religion. We hit every box with the pennant bowlers. And the other thing which I think we try and do in palliative care is to provide hope. And early on, it's the hope for a long life and good symptom management. And towards the end, I think there's the hope of having the confidence that someone is prepared to continue with you and will stay with you and will continue to work with you and your family. And what I see in our team is that presence, that offer of hope, and as best we can, the restoration of relationship. And I reckon that covers compassion pretty well.
Thank you. So we're going to have a pause with the questions and see if there are any comments, questions or reflections from the audience. We've got a couple of roving mics, or one. And so if you have questions, stick your hand up, wait until the mic comes because we are recording this. And then we like nice, short, sharp, focused questions because that means we can get more in. So any questions from the floor or even observations or thoughts? Is it scary? Here, we've got one at the back. Yes, thank you.
Excuse me. I've always been interested in the power of language, and I wondered what the panel think about using the term dying as opposed to passing over or passing away or losing someone.
So it's the euphemisms we use. Yes, who wants to start with that one?
I like the words death and dying, and I think that it cuts across any misunderstandings. So there's been many a nurse in an aged care facility who may have taken a phone call from a wife who's yet to come in, and the nurse, how is he this morning? Oh, well, we lost him. Oh, well, where is he? You know, I think there can be so much misunderstanding. I think the key is that there is a combined understanding of language, and death and dying for me sends that message.
Meg, what do you think?
I feel really frustrated at how many people have passed, and I think we're too.
Yes.
And it is, in its own way, a means of avoiding the finality of being mortal. That's why people say past instead of dead.
Yeah.
But I'd rather we talked about dying,
Yeah.
and then we'd cope with the fact that people get dead.
Okay. Deirdre, are you of the same opinion?
Slightly different. I think I tend to take. I agree with those sentiments, and I think that it is important to be clear. But when I'm working with someone, I think you need to take a cue from where they're at. So you know, one man said to me, "I think I'm pegging out soon." I said, "What's the doctor said to you?" And he says, "I'm dying." So and so we continued talking, but some people can. It's so confronting for them to actually get to that space that they can't actually say that. And I think to push that at somebody, if they really can't process that, is quite destructive and catastrophic. So I guess we're talking about it in different spaces. So a patient in a clinical situation versus a community discussion. But
So it's the understanding why the euphemism is used, and then using that almost as a signal to have the deeper conversation. David, how do you manage these sorts of multiple terminologies?
The first thing is I encourage the medical profession to use it, so in our teams, because we're all human And the same way that there's some discomfort in talking about death and dying in the community, we're part of that community and we share it. So in our teams and in our hospitals, I encourage those words being used by the professionals. In terms of families, if I'm giving information, I will use the word gently because I don't want it to be misinterpreted, and I want to be really clear in what I say, and then I follow the lead from my families and what they say. I think we need to speak the truth. We certainly don't need to use it as a club.
Thank you. Other questions? Yes, one here. Thank you.
Hi, I'm loving what you've all got to say, but I just am really interested in the home-based care at end of life. And Meg, you're speaking my language where I just think it impacts on the whole family and everyone around the patient. I just really was interested how we are going to empower families and people around the person dying to care for people in their own homes.
Okay.
What your thoughts are?
Meg, I think you can start with that one. So how do we provide that support around the family to experience a good death?
I think we need, and you have yet to develop, really thorough community-based supports to enable that, because at the moment it's very patchy. We had a good dying at home because my husband's a specialist doctor, and we have lots of friends who are specialist doctors or nurses. So we had a lot of in-home help just in our social network. And the other thing was you need a lot of other social resources. Say my son was 6'5", so we needed a lot of body lifters and movers just to handle him at that very end stage. I guess what I did realise in the other situations that I saw, and in particular a very close friend who had 12 weeks from diagnosis to death, she wanted to do, which was about 9 months after my son died, have his kind of dying, except she was 130 kilo and her family's understanding of pain management was homeopathy. Now, she had lung metastases that spread to her brain and was psychotic. It was just useless and bizarre and terrible what was happening at home. But once I persuaded her ex-husband to intervene and have her placed in hospice care, it turned around completely, and one of her daughters came to me at the wake and said, I didn't realise how good it could be. And so I guess my view is dying at home is a good aspiration, but what really matters is a good dying, not where the dying happens. So it's a matter of going for where the resources and what the need is.
So I'm going to sort of add another bit to this question and ask David, we've just had a general election. We know that pumping more and more money into health systems is like a bottomless pit. We know that the sort of community-based care that Meg has just described will require a shift of resources. How are we going to do that?
Well, in David's defence, can I say I'd like to see it be additional resources, not a shift of existing resources.
Yes, okay. So that means we need to all start writing to our new MPs. Yes.
I think it's a really complex question with a really complex answer. So I'm going to allow myself that wiggle room. I think we do need to advocate as a community for what we want. I think we need to recognise that we need to ask for patients and work towards dying in the site that they wish, because it's not always home. I have patients who want to stay at home but have young families and want to come to hospital for the last days. So the first thing that I would encourage is a subtle change of language, but try and support people in the site of their wish. The other thing I'm really careful with my families is to say we will do our best to help you honour your relatives' wishes. But we know there are limited resources, and sometimes symptoms and burdens can be too great to manage somebody at home, even with all the community resources that are available. under those circumstances, I think there's a role for bringing home into hospital. And the best example I can give is I had a patient who wrote in their advanced care directive, and I'd strongly encourage you to consider an ACD if you haven't written one. But what this person wrote was, I wish to die in the spring on the side of a hill in the summer sun listening to the birds. And she died on our palliative care ward with the pine forest incense and the forest CD player with her family around her. And it was the best we could do. And I think for her, it was enough.
Thank you. Let's have another question. Yes, we've got one down here.
I think I'm a bit out of my league here, but I'll jump right in with my question. I am old school, and by that I mean about 1,000 years prior. I am all for what work Robert Nitschke is doing. There's the name you all know, I'm sure. Someone has to ask, how far away do you four believe euthanasia and legally being able to medicate our own death is off?
Okay, so Kim, do you want to start with that? Yes.
So what the question, I heard lots of it, but how far away is it? Well, it really depends on our Parliament here in South Australia, but I think by the research around Australia, it's more and more wanted. And it's certainly legislated in Victoria. So that comes into effect on the 19th of June. So, but you do have to have lived in Victoria for some time. So you won't be able to just, travel over there and say, I'm ready to go now. So
you just don't need to buy a one-way ticket.
No. So they have written that in. So look, I think it's a matter of time around Australia, and that has implications for us all. For me, as an educator and a researcher, I'm very concerned that I can equip healthcare professionals who are practicing in that jurisdiction to know what to do and when in delivering excellent palliative care and excellent end-of-life care that may not have anything to do with voluntary assisted dying. The last thing I want is for the young doctor not to ask the question, would you like to talk about the future, because they're too scared to hear what the answer's going to be. And I think for me, there's so much work to do in the next 25 years before I'm on that deathbed to absolutely increase the quality of end-of-life care. So in answer to your question, I don't think it will be very long. Looking at the research that I've looked at, public opinion, depending on how the question's asked as well. But certainly the ground is shifting.
Meg, is that your thought as well?
In some ways, I guess personally I don't really know. So personally I don't really know. Most of my peer group, we're baby boomers, we control everything and we want to control our dying, and most people I know say they want to have their box of pills or whatever it is, and make that choice. The only thing I would say is, having seen a range of well-managed dying, it can actually be an okay thing. But we've got to put a lot of work and effort into developing the quality of palliative care to enable that. And that's not mutually exclusive with people being able to choose to exit at their own time. Deirdre, David, thoughts?
I think I'm going to comment on it from a slightly different perspective. And that is, in Oregon, euthanasia has been legal for the last 21 years. And also, I think, in Washington State for about the same, for about 7 or 8. And they've been recording for the last 21 years why people choose to end their life. And there are 2 reasons that are high on that list that have remained in the high 80s, low 90% ever since. And that is losing autonomy and not being able to enjoy and take part in things that they enjoy and activities that they want to enjoy. So for me, I guess with my OT hat on, occupational therapy hat on, that's very much a lot around function. And I think that comes back to that community model of care as well, that if, given that people are living for longer, there is still this drive to keep as active as possible for as long as possible. And we need to look at ways to both support people to be active as they experience this functional decline, but also to help and support carers in that space as well, because it's one thing for two nurses to be moving somebody around in a hospital ward. It's really different when you're at home and there's just one or two of you and you've got carpet on the floor so the hoists don't slide on the carpet, and it just doesn't work the same way. So I think that is a really interesting spin for me, that it's that stuff around function and being able to move and being able to have control over what's happening to you that are the primary reasons that people have been choosing to end their life.
I think the key challenge for us is going to be communication. I think as a profession, I don't believe it's a case of euthanasia or palliative care, but how we talk to each other, how we interact, and the reflections that we receive in that. And I think even more importantly, at individual level, the most important question I can ask somebody is, tell me more. Tell me what you're thinking. Tell me what's important. And doing a lot of listening. And I think this is something that we're going to see come up time and time again in Australia and New Zealand, and we're seeing that now. And the challenge is going to be, how do we treat each other with respect? How do we listen? How do we work together?
I think do you want to have another comment? Yes.
I just wanted to say thank you. I've just read data that Australia is supposedly going to have a population of 35 million in 2050. Our hospitals are certainly not going to be able to upkeep with such population growth, and we are living for an incredible amount of time longer than what we were 50 or 100 years ago. So having that option there, I think, is very important for humans to be able to call when they want to make it the end, when they want to call it quits. Thank you all, panel. Very interesting output.
So it could be, ironically, that passing a euthanasia bill will improve palliative care, because people will be, in a sense, forced to make a decision. Do I want to actively make a decision about when I die, or do I wait? But whatever way it could alter the sort of work that you guys do, that's just a reflective thought. Any more comments? Any thoughts about what we've just been talking about?
My only comment is that when people talk about assisted dying, they tend to focus on the when, and palliative care is really focused on the how. And that's why I say that, there's a lot of room for improvement and extension of palliative care.
Any other questions?
Sorry, I might just briefly. I would be very, very keen to completely separate voluntary assisted dying from an economic argument or a population growth argument. I would strongly support completely separating those elements. I would agree. I think there is an opportunity with the bills being introduced to improve palliative care services, because I think having equitable palliative care across the community is really important for the introduction of alternatives such as voluntary assisted dying.
Yes, we have a question right at the back.
Hi, I've just got a bit of a reflection and I guess a question. I'm wondering when people are drawing up wills for end-of-life care, or if you're suddenly placed, say, as a friend or family to be the medical, I'm not sure of the word, directive advocate, where there's a sudden, someone might turn up in A&E and they're at the end of life, say from where in their directive it's to not resuscitate. And then when people are asked to actually step forward and they're signing up with their friend to say, yes, I'll take that on, what sort of education do lawyers get to sort of help those people pick their people and make their choice, and then let that person know actually what that really does mean when you have to turn up to A&E and make that choice?
Yeah, so, and also my concern is version control. Have you got the latest version? So, David.
Again, these are really valuable questions. So I'm going to take the will out of it. The will that we talk about is what happens once you've died, and it's the financial and what happens with assets and those sorts of things, and lawyers are absolutely involved in that. What I think you might be asking is about the Advanced Care Directive and the 7-step form, which is a statement of what's most important to you. One of the things that I delight in these forms is it tells me that the conversation has happened, that you've spoken to the people or the person who could step into your shoes and speak as if they were standing in your shoes at the time, and that they know what's most important to you. And the form, whether an Advanced Care Directive or a 7-step, is a way of putting down on paper what those wishes are and how you wish to be treated if you cannot tell the doctor yourself how you wish to be cared for. In this state, the refusals are absolutely binding. So if you tell your relatives, I do not wish to be resuscitated, and it's written down on a 7-step form filled in by a doctor or an Advanced Care Directive, then we do not resuscitate. The issue we have is you can't write down on a form treatments that you want, because it's still a question of whether it's felt that it will help you under those circumstances. So we can't say that I'd like to go on a cruise ship in the last week of my life.
So, David, a hypothetical. Let's say there's something been written, but the last gasp of the patient who's gone into ED is saying, I've changed my mind, I want you to resuscitate me. What happens then? Has that ever happened?
So the answer to that question is these forms, that they're a fluid document and they can be altered based on your wishes. But the important thing is the ongoing conversation. And what we often find is that the way I would frame it is I think we try and help people live as well as they can for as long as they can. And at such time as they're dying from a disease, then I don't offer resuscitation under those circumstances, because I'm already doing and already done all that I can to help them live as well and as long as possible. And I think if we honour that in the care of everybody in the community, then these issues don't often come to the forefront. But the important thing is that conversation. When you're well, talk to your families, talk to your doctors about what you value, what's most important.
So do a bit of audience participation. Hands up who's heard about an Advanced Care Directive. Okay, everybody, hands up who's got one. Halfway. So that's like 20% of the audience. Yes, okay, so that's pretty good. So next time it'll be 100%, isn't that right? Yes, okay. Wait till if we get the mic's coming.
What I noticed is the gap in this is, so the person that has done the directive, they've got their person in mind, but there's a gap in the education for the person that's actually signed, and then they turn up at ED and then they have to make that horrible decision, and then what? So unfortunately somewhere there's a gap,
Yeah.
that would be nice to address that
So, Kim, I know David wants to say something, but maybe your life essentials, end of life essentials, has something in that.
I just think it's a really good point that you make. There's a group out of Queensland University of Technology, a group of lawyers who are doing a lot of work in this space and advising healthcare professionals. But I think it's a really interesting point that you make, that you haven't had any preparation for this role. So, you know, what would be expected of you, and what education or what guidance are there for the people who sign up and say, yes, I can be that person for you. It's a really, really good point.
I would fully agree with that. The other thing which I think is really important, and we were talking before that language is really important and how important that is. And I think one of the responsibilities of us in the medical profession is not to say, what do you want done for your loved one? Because I think that puts a burden on our shoulders, which is not ours to bear. And I think that's incredibly unfair. And what I would encourage us to say is, if your loved one could tell us at this point how they want to be treated, given what's going on, what would they say? And with that answer, I think the role of the medical profession is to explore those values and to help guide in that decision making. Because what I'm hearing you say is that it's a burden that shouldn't be placed on your shoulders, and I wholeheartedly agree.
So a lot of conversations, a lot of talking, a lot of questions, what matters to you, so that families are informed, and then the right sort of dialogue and communication with the health professional team. I think we've got time for just 2 more questions, so we've got one here.
I guess it's just a statement in helping a lot of people do advanced care directives. The South Australian form actually does say that as a substitute decision maker, you need, and part of my education is, and I hope lots of lawyers do too, is your role is to represent what you believe that person would want. And I would hope that lawyers are actually saying that when they do. As a social worker, when I help people with advanced care directives and substitute decision makers, I'm always very clear, you're not going to be making a decision, you're going to be representing what the person you're signing for has told you they want.
Yeah, and again, using Kim's metaphor of the structure around giving birth and antenatal, peri and postnatal, it's almost that we need to start to structure our conversations about end of life and have it almost that it's just the norm, that you have your advanced care directive, you have your conversations, you make sure that the lawyers and the health professionals are in tune, and it's no longer strange that these are the things that we do. Okay, there's one more question, and I think I think this may be the last question, so...
So I work in adult rehab, so this area is definitely not something I feel skilled or knowledgeable about. But my perspectives are that sometimes in rehab we can be almost aggressively blind to death or decline, and it's just not an option. And I think that reflects medical professions and health care more broadly. Do you feel that... I think there's a need to start accepting reality, but are you seeing that? Do you think that that's a new thing that's coming through, or?
Deirdre?
Yeah, I think it's absolutely changing. I used to manage a rehab service, and I worked in the palliative care. I worked on the palliative care ward, but I managed the rehab team. And there are differences in approaches in terms of how to mobilise people. There's differences in evidence around, if somebody's fractured a neck of femur, that to get them up early and mobilise, there's better outcomes. It's harder to say that for palliative care, and what exactly are the outcomes, and that's one of the big challenges for clinicians, I think. But what I've noticed changing in the last 10 years in particular is that palliative care, people with palliative care needs are everywhere. They're in acute hospitals, they're in rehab, they're in ambulatory care settings in the community. So people with these needs are everywhere, and I think it's what's being taught in curriculums is starting to change. in terms of how to push or not push. How do you actually rehab somebody with those kinds of needs? So I think it is changing. I ran a study earlier on this year, and I was asking occupational therapists and physiotherapists if they would help out as research assistants. And one of the things I was very conscious of was, would they actually have, how would they feel about going into somebody's home if they knew that they were having palliative care? And all of them said, yep, that's not a problem. We see this all the time now. So I think there is a shift. And going back to, there are not enough palliative care beds to look after people who have palliative care needs. So I think every health clinician, there is an onus on them to developing some competence and confidence in being able to at least start to have discussions and how to work with that person. And I think it's simple, but it comes back to what's important to you right now and what do you need from me and how can I support you in that.
David, in terms of symptom control and managing functional decline, those are both very, central interventions and rehabilitation techniques as well. How do you make that balance between, I think what you're suggesting is the almost aggressive approach to getting people better rather than using those skills to help people die well?
I would echo what Deirdre has said. I think we need to continually reassess our patients, their goals of care and how they're going clinically. And we need to respond to the changes that we see in our patients. I think with palliative care, we've certainly been at risk of setting ourselves up as the experts in death and dying. And I think that what we're seeing now is a more appropriate attitude in that death and dying is everybody's business. And it's less being siloed, it's less being the experts, but it's supporting our colleagues in every specialty. And when some symptoms are particularly difficult or challenging, providing that little bit of extra support. But I think that general support of our colleagues across all the branches is the challenge that we face and that I see us moving forward in.
Could I just add on to what David said? I think that's one of the big differences between rehab and specialist palliative care is that palliative care is very acute medicine, and one of the challenges is around staffing. So in rehab, for example, you often don't have physicians in over the weekend and symptoms can change really, really quickly. And what worked at our site was that we had palliative care and rehab co-located. The palliative care consultant and the rehab consultant work very, very closely together. So we would move patients from our palliative care unit to our rehab if we wanted them to get more rehab. Or if there were rehab clients that had palliative care needs, they would come into the palliative care ward. Interestingly, the rehab physician would not take patients from the psychiatric ward as readily. And the primary reason for that was not because of the complexity of the care. The primary reason for that was, she said, when I need to speak to Brian, who was the palliative care physician, he would answer me on the weekend. He would send somebody out to come and see the patient. So she was not left hanging, trying to work out the best management for the patient, because there are some very different care needs and staffing levels. Same with nursing, higher levels of nursing and acute than in rehab. So it's not a simple thing, but I think it goes to how models of care need to be changing and need to be evolving to manage these situations.
So, last job of the panel is to take home message. What final 5 words would you say to people who've been listening to you for the last hour? So what is for you the most important thing for them to reflect on? And I'm going to start with Kim.
So talk about it.
That's it, talk about it. Good, yes. It's just really short.
Okay.
So once the full stop comes, I'm going to stop you, yes.
As a carer, understand that you're part of a team, that's family and friends, that's the health professionals and the patient.
Lots of commas in there, but we let her get away with it. Deidre?
nothing's set in concrete. You'll keep coming back and asking questions about care. Nothing's set in concrete.
That's it. And
She got longer
yes.
than you.
No, she didn't. That was a semicolon I saw creeping in. Yes. Okay, David.
Talk.
Excellent. Oh, I think David gets it. Yes. Okay. Well, look, you can see that absolutely no expense has been spared tonight. So, guys, don't choke on the wonderful Higgs chocolates. Thank you so much for being wonderful panelists, wonderful presentation, wonderful audience, and just let's keep talking about death and dying. So thank you all very much, and see you at the Brave Lecture.